A 50-year-old male has a large growth in his upper jaw. Check out the full workup and surgery today on the Open Reduction. Welcome to the Open Reduction, your channel covering all topics oral and maxillofacial surgery. I'm Dr. Tom Bolten, and today we're removing an enormous cyst in the maxilla. This patient is a 50-year-old male who feels like there's something expanding in the roof of his mouth. He has a retained primary canine and maxillary exostosis bilaterally. There is significant dental crowding, and I'm able to palpate something in his left palate and alveolar bone. This area is asymptomatic. I take a cone beam CT, and clearly we have a large problem. There is a unilocular radiolucent lesion in the left anterior maxilla associated with an ectopic retained canine. The tooth is violating the floor of the sinus cavity. This radiolucency is causing bony expansion, especially towards the palate. The differential on this lesion includes an odontogenic keratocyst, an ameloblastoma, and a dentigerous cyst. The treatment involves exposing the site, removing the ectopic canine, cleaning this lesion out, and submitting it to the pathologist to obtain a definitive diagnosis. This procedure is performed in the office under IV sedation. Once the patient is asleep and the area is anesthetized, I aspirate this lesion to evaluate the contents. We can see there is a thick brown substance within the lumen of this lesion, and the 3 cc syringe fills quickly. Next, I make a sulcular incision and create vertical releases so I'm not fighting the soft tissue. I elevate a full thickness mucoperiosteal flap and identify the location of the canine. Next, I use a round burr to uncover the canine. Now that I can see the crown and a large portion of the root structure, I elevate and remove the majority of the canine. Unfortunately, the tip of the maxillary canine is free floating in the sinus. I don't want to lose this root tip into the sinus cavity because it changes the size and scope of this procedure substantially. I would need to perform a Caldwell-Lux sinus surgery and explore to retrieve the root. To avoid this, I expand the extraction socket so I have more access to this root. I gently use the suction to manipulate the root back into the extraction socket, and eventually I'm able to retrieve it. This is a huge relief and saves a much larger procedure. There is a communication with the sinus, which I'll address later in the surgery. Now I need access to this lesion, but I don't have it through the extraction socket. I make a bony window and locate the lining of this lesion. Now I have access and I begin to curette the lining off the bone. Here is the majority of this growth. I continue to curette and scrape the bony walls until I'm confident I have everything. Now I rinse and confirm I'm looking at nothing but healthy bone. Finally, I close the site primarily. This patient received very good news from the pathologist. This lesion could have easily been an odontogenic keratocyst or an ameloblastoma, which would have required additional invasive treatment. Thankfully, this came back as an inflamed dentigerous cyst. A dentigerous cyst is a cyst that forms around the crown of an unerupted tooth. They're fairly common, but the vast majority are not near as big as this one. The treatment is enucleation, which I already did, so nothing else needs to be done. The bone will fill in with time. Thanks so much for watching. Please click those like and subscribe buttons and check out my channel for additional interesting oral surgery cases just like this one. Also, if you're a provider, visit my website, theopenreduction.com, for continuing education credit. I'm Dr. Tom Bolten. I'll catch you next time on The Open Reduction.